Yeah, it's a long time since I've spoken here. I still recognize some of the faces, but most of those faces have now got white hair on top. And there are all these youngsters, these young faces that I don't recognize, like you, for instance. So we've got 5 talks this evening. That sounds like a lot, but we're going to stick to 20 minutes per talk. Technically, that leaves 10 minutes for questions between the talks. And if there are no questions, then we go home early. I encourage you to actually ask the questions rather than text them. We are both quite nice people, and we won't be rude. Promise. So, allergy. I think tonight you can take this as your chance to learn something that's going to earn you easy brownie points with your patients. And I say that because we hear all the time from patients how frustrated they are that they've spent many, many years with symptoms and never had clear instructions as to what can be done and how it can be cured, how they could be cured. And those of you with severe allergy, and I'm sure there are a few of them here, will understand just how frustrating it might be to be in that position. So I'm a GP, but one day a week I'm a gypsy, a GP with a special interest. And I work at the Waikato Allergy Clinic, which is run in Graham Curry's facility in Victoria Central. The background is that we used to run this allergy clinic at MedLab in the days when there was a MedLab. And when MedLab folded and I headed off for Australia, I asked Graham if he would take over the patients. And he did so successfully, and the clinic kept going. It grew a little bit. And when I came back about 7 years ago now, I asked if I could rejoin him, and he made me welcome. So that sounds good, but at the end of this year, that building is going to be torn down, and we have to find a new home for the allergy clinic. The new facility probably won't have extra room, the way the current one does. So I'm looking for a host somewhere in Hamilton, anyone who's interested, to host this clinic one day a week. Anyone who's interested, please contact me. So here it is. Our first talk is on Allergy Basics. Then Nick is going to speak on childhood food allergy. Then I'm going to talk about a case of asthma, which was very challenging and instructive. And then Nikki's going to talk about a difficult case that she had to tease out. And finally, I'm going to talk to you about, well, I'll tell you the answer. It's supposed to be a mystery, but it's IBS. And the background of this slide is to remind us that there's nothing basic about allergy. Nobody can honestly claim to understand immunology or even allergy. Obviously, a huge amount is known. There have been literally millions of men and women hours, spent in laboratories, teasing out the immune system. Nobody understands it. Right. A couple of fast facts about allergy. I think everyone understands that allergies are very common. They reckon about 25% of people have some allergy if you ask them. Obviously, most of those are minor and not clinically significant, but it is a very common condition. The incidence is rising. Now, that's not just an observation or an anecdote. The best evidence, I think, comes from Denmark, where the medical system is such that you can access everybody's medical records, full medical records, on the same computer system. And they have shown very clearly that the incidence of things like food allergy has grown almost exponentially over the last few decades. There are various theories as to why that might be, but once again, no definitive answers. The third thing I want to say is that In a sense, allergy is not a disease. It's an imbalance in the immune system. We all have some IgE function. Some of us have too much IgE function. Nobody knows why. But it's more of a dis-ease than a disease, if you want to think of it that way. Now, allergy is a multi-system condition. So, we tend to focus on the nose, the lungs, and the skin in allergy. But allergy, if a person in the middle of an allergic attack will tell you that it affects their thinking, it affects their mood, it can affect their guts. Anaphylaxis affects a lot of things. So it is a multi-system disease, and you must bear that in mind when you're trying to deal with allergy. Stress makes allergy worse. Allergy can interfere with your sleep, can put you in a bad mood. In fact, I'm remembering a patient who told me that her husband was so much nicer since I'd fixed his allergies than before. So much less grumpy. So some basic questions. Why does, for instance, the same allergen in if two different people are allergic to the same allergen, why does the one get asthma and the other one eczema? Or how come a child with a particular allergy will have eczema, grow out of that, and then develop asthma? Don't know. Why does the condition maybe start in youth and get better? Or why is it maybe not there in a youth, but hits someone when they're 23? Don't know. But all of those situations, just because you don't know, it doesn't mean it's not allergy, I think is what I'm trying to say. So we talk about the allergic triad, or the atopic triad, and that is asthma, eczema, and hay fever, or allergic rhinitis, I should call it. Right. A couple of fast facts about allergy. I think everyone understands that allergies are very common. They reckon about 25% of people have some allergy if you ask them. Obviously, most of those are minor and not clinically significant, but it is a very common condition. The incidence is rising. Now, that's not just an observation or an anecdote. The best evidence, I think, comes from Denmark, where the medical system is such that you can access everybody's medical records, full medical records, on the same computer system. And they have shown very clearly that the incidence of things like food allergy has grown almost exponentially over the last few decades. There are various theories as to why that might be, but once again, no definitive answers. The third thing I want to say is that, in a sense, allergy is not a disease. It's an imbalance in the immune system. We all have some IgE function. Some of us have too much IgE function. Nobody knows why. But it's more of a dis-ease than a disease, if you want to think of it that way. Now, allergy is a multi-system condition. So, we tend to focus on the nose, the lungs, and the skin in allergy. But allergy, if a person in the middle of an allergic attack will tell you that it affects their thinking, it affects their mood, it can affect their guts. Anaphylaxis affects a lot of things. So it is a multi-system disease, and you must bear that in mind when you're trying to deal with allergy. Stress makes allergy worse. Allergy can interfere with your sleep, can put you in a bad mood. In fact, I'm remembering a patient who told me that her husband was so much nicer since I'd fixed his allergies than before. so much less grumpy. So some basic questions. Why does, for instance, the same allergen in two different, if two different people are allergic to the same allergen, why does the one get asthma and the other one eczema? Or how come a child with a particular allergy will have eczema, grow out of that, and then develop asthma? Don't know. Why does the condition maybe start in youth and get better? Or why is it maybe not there in a youth, but hits someone when they're 23? Don't know. But all of those situations, just because you don't know, it doesn't mean it's not allergy, I think is what I'm trying to say. So we talk about the allergic triad, or the atopic triad, and that is asthma, eczema, and hay fever, or allergic rhinitis, I should call it. Right, so some pictures. And this is the allergic triad. Let's start with number 1. Allergic rhinitis. These are obviously quite extreme photos, but the guy on the left, he came in the morning, desperate. He'd spent the evening before cleaning out his storeroom. And he spent the night, as you can maybe see from his mouth, he couldn't breathe all night long. Probably rubbing his eyes, and that's why he's got this violaceous, destructive sort of edema around his eyes. And his nose, you can see that nose is just inflamed. The little guy on the right, you'll see a lot of those guys with their summer face. Pretty miserable existence. Okay, number 2, asthma. You might look at that person and say, oh, well, yeah, that's a normal person. And most people with asthma look normal. You know, I don't know who's got asthma, but there'll be 1 or 2 here. But I think what you can pick up from this picture is the anxiety that's there. This is someone who's fighting to breathe and knowing that it could get worse. And I don't know who went to the lecture on asthma a week ago, but some figures out of there, 60 people a year die in New Zealand from asthma. And Kat Chang gave a figure, I think it was 26% of the people who die did not have severe asthma. They spend most of the time with no asthma symptoms. So it's not just people with severe asthma who die. Sorry, I want to just say one thing about the allergic rhinitis. It's not just the nose, of course. It's the palate. Some people get itchy ears, eustachian tube dysfunction, obviously the nose, epistaxis, sinusitis, allergic conjunctivitis. Oh, I didn't start my timer. About the asthma, I wanted to say also, what's the pathogenesis of asthma? Asthma is characterized by chronic inflammation of the bronchial lining. That's asthma. And it's reversible with the right drugs. How does allergy cause asthma? The inflammation of the bronchi is eosinophilic. So there's a direct link to allergy. I know that's not an answer because it doesn't explain exactly how it happens. But basically there's an allergic inflammation of the lining of the bronchioles. Now, number 3. You all know what that is. Eczema is my personal pet hate. I've never had eczema. I've never had a kid with eczema, but I've seen so many kids suffering with eczema that I just hate it. because of the misery it causes. So we really should talk about dermatitis. We tend to leap into the phrase eczema, but eczema is a chronic condition. Neither of these kids have got eczema. It's a chronic condition which is caused by scratching at an itchy portion of your body. Typically the soft skin of the creases, but it can be anywhere. So the actual eczema is actually a lichenification. It's a chronic thickening and damage to inflamed skin. So this really, you'd have to call it dermatitis. So this girl on the right, patchy dermatitis, which is associated, I forget exactly which allergen, but it's an inhaled allergen. And the little fellow on the left is only a few months old, and that was a food allergy. I'll give you a little practice tip. A previous doctor had written dribble rash. But I looked at this child and I thought, it's unusual for a child to dribble into his ear. Just a couple more, because I hate eczema so much. In these biting insects, obviously. Here's our friend the German wasp, Vespula germanica, and that lady up top there has been stung. She's on her way to the hospital. She was stung 5 minutes ago by a wasp. And then, of course, there's drug allergies, which we all have to deal with. Right. Let's get to diagnosis and treatment. So the mainstay diagnostic test we do is the skin prick test. You have a positive control and a negative control. The negative is water. The positive control is a solution of histamine, and that would be and then a range of allergens which you put a tiny drop on the skin and you use a very standardized pricker to push them intradermally, not through the skin, just intradermally. And after 15 minutes or so, you get this wheel and flare reaction. And when you've done enough of these, you can judge not only what's positive, but how important the allergen is in terms of its reaction. The other test, of course, we've got is the RAST, which you have direct access to through your laboratory. So here's a bit of a comparison between the two. The skin prick test, yes, you do have to travel to a special clinic to have it done, but it's very sensitive. It's very cheap, relatively speaking. It gives an immediate answer, and it's an answer that the patient can see and experience, which is very important for them. And we can optimize the allergens we used for the treatment we've got available. The RAST, which is the specific IgE test, is relatively expensive. I think it's about $40 an allergen that you ask for. It needs blood drawn, and obviously in a small child that can be a problem. But an advantage is that you've got a very broad range of foods that you can test for, and we use it for that. Sometimes these tests don't agree with each other, and in a number of cases, the skin prick test that I do is negative, and I don't believe that, and I then ask for confirmation with a RAST, and sometimes it gives a different answer. For reasons which I've got clues about, but I don't really understand. And treatment. Now, obviously, we could give a few lectures on treatment, but that's my 5-minute call, hey? But I'm going to really stick to one slide because you don't need to know the details. There are two main classes of treatment. There's symptomatic treatment and curative treatment. Symptomatic treatment is perfectly suitable for mild cases of allergy. If a person's happy taking an occasional antihistamine, or they're happy on their puffer, leave well enough alone. But you do need to think, and maybe think to ask these people, are you really happy? Is your asthma really controlled? Do your family members hate the way you sniff and sneeze all the time? You may think it's controlled, but do your family members think so? Are you in optimum health? When symptomatic treatment failed or is unsuitable or they're tired of taking pills, you have got immunotherapy as an option. One problem I have with symptomatic treatment is that all of them are designed in some way to switch off or kill or inhibit part of your immune system. Immunotherapy does the exact opposite. So immunotherapy involves a protocol of injecting the specific allergen into a person. It's a long process, takes at least 2 years. It requires regular visits to the clinic. But it's got certain huge advantages. One is that if it's successful, it's probably curative. And curative means they will never come back to the allergy clinic and they won't complain about their sneezing, asthma, whatever again. It also requires a financial commitment. It is not funded by the Waikato DHB anyway. Most DHBs do not fund it. But it's what we do. I do it partly because of the satisfaction that it gives me to see patients cured. Just a couple of weeks ago, this patient walked into the clinic and, that was her name, Candace. I looked at her, my mouth fell open and I said, Candace! There's this tall blonde woman with 2 little kids. Now I remember her from when she was 12, going for her desensitization. And she's now a deputy principal somewhere, and of course she's got allergic kids. But it was a huge satisfaction to see her at least cured of her allergies. And she was a battle, I remember that. Okay, some of you, bless you, are the type of people who demand evidence. So I'm going to list some Cochrane reviews for you. There at the top is a review on allergic rhinitis from 2007. There probably are newer ones, but we don't need newer ones because that one was pretty definitive. There's no question that desensitization is good for allergic rhinitis. Asthma, there's a more recent one, 2016. There's still not enough studies to come down hard on the side of immunotherapy, but there are certainly studies that show that immunotherapy is just as good as inhaled corticosteroid in dealing with asthma. Eczema is much more controversial. There aren't any decent studies, and frankly, I couldn't be part of a study where I was injecting some poor kid with water just to see if they didn't get better. So there aren't enough studies, and I think it's fair to say that where we are today, allergists will treat eczema with desensitization, dermatologists will not. But I'm quite sure that the dermatologists will see the light in due course. So here's my key points. Remember the atopic triad? You need to think when you're faced with this patient whether it's okay to keep on just treating or initiating treatment, or whether they actually need a diagnosis and maybe something better than just antihistamines. And you need to, it's part of the same point really, you need to consider whether symptomatic treatment is good enough or whether you want to go for curative. Right, so I think that was the first one. So technically we've got 7 or 8 minutes for questions. Oh, yes.
So the question is it common for a person in their 40s to develop respiratory symptoms, anaphylactic reactions to
Fluoxetine, flucloxacillin.
Sorry, even though there has been no problems with augmentin in the past.
Is it common for a 40-year-old woman to develop severe anaphylactic reactions to flucloxacillin even though augmentin has been used in the past? Well, clearly it is possible because it seems to have happened. Common, certainly not. But I think the point is nobody really knows why an allergy starts. It's probably not a single factor that induces allergy in you. There might have been 3 other things happening at the same time as the fluclox.